Okay, good morning. My name is Richard Stein. I'm a gastroenterologist in New Zealand. You can probably tell I'm originally from the States, but I've been here over 10 years. And I'm also co-chair of Crohn's and Colitis New Zealand, which is an organization not just for patients, but also to support doctors. One of the biggest things that we've done in the last year is this burden of disease report about the effects of IBD on New Zealand. As you probably know, in New Zealand, there's really not a lot of information about inflammatory bowel disease. The Ministry of Health doesn't even list it as a chronic disease. It's listed as a non-communicable disease. If you go into the New Zealand Ministry of Health publications, it's referenced that there are 15,000 people with IBD in New Zealand, but that data really is pulled out of the air. Nobody really knows. And the truth is that the ministry really has never studied IBD or evaluated its impact on New Zealand. A couple of years ago, there was an article that came out of the Canterbury group looking at the incidence of IBD over the last 10 years. There's very, very few DHBs that actually have databases or keep records of their patients with IBD. But the striking thing about this study was that it appears that there was an increased incidence over the last 10 years of over 60% growth in the incidence of IBD. So our report was funded with not a lot of money. We got a $40,000 grant to conduct this study. We contracted a health economist and a statistician. But we had several people that participated in the study. We had over 20 people in our working group. There were several doctors, gastroenterologists, IBD nurses, psychologists. We had GPs, and we had patients on this group. And we got this information. A lot of it's just extrapolated. It's not a particularly scientific study because we had to use limited data and extrapolate for all of New Zealand. So that obviously opens us up to you can criticize or challenge some of the results that we have, although it's really the best that we can do. We used IBD databases from 5 DHBs that actually kept records of their IBD patients. 2 of them from DHBs where I've worked at Hutt and Wairarapa. We got a lot of information from Canterbury on Otago. We used national hospital admission data. We also conducted a survey from our organization's database, and we had over 200 people complete the survey, which was a lengthy survey. Over 300 people actually did part of the survey, but we used data from the 200 that completed it. And we got information from Pharmac as well as recent studies. And the result was a 60-plus page report on the burden of disease. So what were the findings? As of the 31st of December 2016, we estimated that there were over 20,000 people in New Zealand with inflammatory bowel disease. We also found that delay in diagnosis was the status quo. Over half the people, it took them over 2 years to arrive at a diagnosis from the time when they first presented with their symptoms. 6 months. About 20% it took over 2 years. We also found that the quality of care, access to medications varied widely depending on where you lived in New Zealand, and that there's also a tremendous economic burden to the disease. New Zealand has a very, very, very high prevalence of IBD. 1 in 2,027 people, we estimate, has IBD. The prevalence is growing at a pretty alarming rate in this country, as is the incidence. And if you look at New Zealand in comparison to the other countries of the world, we currently rank around 3rd in prevalence. There are huge costs associated with IBD. We look back at hospital admissions where IBD was the principal diagnosis over the past 10 years, and there were over 28,000 admissions. We looked at the pharmaceutical costs, and these have really been spiraling since the biologics became available in the country. And It's estimated that there's over $30 million spent annually on IBD, and it's probably much more than that because we couldn't extrapolate data from Remicade, infliximab, because it's used from so many different, for so many different indications. There are also huge indirect costs. There's, the costs for families having to take their children to the hospital. There's time lost from work. There's out-of-pocket expenses, which are significant for families of people with IBD. There's the issue of absenteeism from work. Close to 10% of people lose over a month of work from, due to their illness. And then there's the issue of presenteeism, people who are able to go to work but really aren't able to work at 100%. And those, that additional work has to be shouldered by their employees, other employees or their employers. And we estimated also that the annual cost of IBD to New Zealand is close to $250 million a year, and it seems to be increasing. So these are the conclusions. We found a lot of weaknesses in the current model of care in New Zealand. New Zealand, the prevalence is increasing. The incidence is increasing at a very, very, very fast rate. Why it's so high in New Zealand, we really don't know. We have a lot of theories, genetics, lack of sunlight, vitamin D. Deficiency has been queried. There's tremendous inequality of delivery of care throughout New Zealand, and there are a lot of reasons for that. There's lack of awareness, among primary care doctors. There's lack of access to doctors, specialists at the hospital, long waiting lists. And there's also a lot of inequity in terms of resources based on which DHB a patient happens to be centered in. I also work up in Kaitaia once a month, and there's the very north end of the island in all of Northlands. There's one gastroenterologist. While in Auckland there are several, we have 3 in Lower Hutt. But just as an example, Northlands is a huge DHB of over 150,000 people, and there's one gastroenterologist. Access to pharmaceuticals varies quite a bit. Your chances of having access to biologics in New Zealand really is determined by where you live. There's also, problems with how biologics or access to some of these more expensive medications is made available to patients. The way we have to get access, people have to first be on prednisone, then they have to be on an immunosuppressant before they can get access to more effective medications. Healthcare planners, particularly the Ministry of Health, really don't have any idea about the impact of IBD or really how we should be approaching the problem. If we do make diagnosis earlier, it's kind of a no-brainer that we'll have decreased hospitalizations, emergency room visits, less morbidity. We really need to get away from the reactive way that we treat patients. We usually wait until they have a flare before we do anything rather than giving them ongoing care. So what CCNZ is doing now is we're establishing an IBD national working group, which is already in process, so we can develop best standards of care, make recommendations to the government. We're having ongoing meetings with the Ministry of Health and Pharmac. We just had a meeting where we met with researchers throughout New Zealand who are looking at IBD so we can coordinate research. And we are also in the process of preparing an application for a health research grant of $5 million. So these are some of the websites. The first is the website for our organization. We have a 24-hour Ask IBD line for patients. You're free to email me at any time. If you want a copy of the Burden of Disease report, you can just send an email to info@crohnsandcolitis.org.nz. burden disease report is also available online. Thank you.
Thank you very much. Morning, everyone. So the value of shared care, well, first of all, what is shared care? We haven't decided what that is. Maybe I can talk about that a little bit. And more importantly, do we need to share the care? I mean, historically, IBD is a specialized condition looked after by specialists in the hospital. But you heard what Richard was talking about. The burden is too high for us to handle. The hospital waiting list and the pressure on the hospitals now is unacceptable. And it is a chronic condition, which is a shame is not classified as such. So we get those patients as a young teens sometimes, and they live 50, 60 years with the disease. You know, their specialists retire, their GP retire, and we need to organize for them how we're going to look after them. And it still is a learning process all around the world, as I'm going to allude to soon. Then we have to value this share. How do you value a share? It's a relation between four different parties. The patient at the center, the IBD nurses and the nurses, with the specialists and the GPs. So how are we going to evaluate this relation? How are we going to make sure it works? And you'd be amazed how little there's out there about this subject. Well, first of all, we will need to decide what is a good IBD service. And this is what's been already, as you see up there, sorry for the busy slide, but this is very much patient-oriented, 10 essential good IBD service, which talks about all the different points. You know, they talk about having a team. They talk about who's going to look after them. They talk about joint care. And you know, I'm not going to go through the whole list, but this is really what we should aspire and achieve. And it's very much patient-oriented. For the reason I mentioned, the patient is going to suffer. We look after them. We change with time. So we ask ourselves the question, so how are we going to share it with the GPs? First of all, you know, how are we going to are we going to educate the GPs and keep giving them advice all the time? So someone thought about it and said, probably guidelines is a good way to go. And you know, someone sat and read guidelines. In fact, there's the study done in Leicester, the Production and Evaluation Guidelines for Management of Inflammatory Bowel Disease, and published in 1999. That tells you a lot. A study is first published in Postgrad Medicine, and in 1999, so there's not much work done about it. And I'm going to go in a bit of details because that should interest you in terms of what's happening there. So it's 487 GPs, and all they look after stable IBD patients. The numbers were not really mentioned clearly in the study. They've written quite an extensive guidelines for them. I didn't also put the details because it's not the issue here, and they did teaching studies about them, and they gave talks about them all the time. And they wanted to measure the effect over 2 years, 24 months. And they organized mobile patient support, and the endpoints were to see what's the content of the referral letter, has it improved, to look at the time between the referral and the first consultation, which is almost the same point, i.e. has the content stimulated the hospital and the specialist to see them sooner, and the ability of the GP to predict the diagnosis, has that improved? And of course, some of the tests, whether it's needed to be repeated or not. So those were the kind of endpoints to assess this study. Then, before I go about complete results, they decided to ask the patient. Halfway through, after they'd written the guidelines, they said, oh, we forgot to talk to the patients. Let's go and check with them first. So, you know, patients were mostly happy. They were worried about whether the GP can manage their IBD. And that's the thing, because it's been always kind of, in people's mind, this is a highly specialized condition. It has to be done in the hospital with a specialist. So quite a few patients were quite worried about, will my GP be able to handle it with the knowledge? And quite a few patients wanted more information to decide. Then halfway through the study, after a year, and there's a reason why they did that, they decided to go and ask the GPs if they are using the guidelines. So only 32 replied. In fact, 20% only replied. The other 12% they had ended up calling them. And so only 32 of the patients replied whether they are using the guidelines or not. It wasn't a great start. And 43 of that, so 12% of the total number of GPs only used the guidelines to refer, and 10% used it during the consultation. So this was obviously a bit of disappointment for the organizers of the study. And then let's look at the endpoints, each one of them that was listed there. Has it improved it at the end of the study? This is after 2 years, of course. So the content of the referral letter, not really. It didn't improve at all after the extensive guidelines and the teaching and following the patients. Time between the first referral and consultation, again, didn't improve. Ability of GPs to predict the diagnosis didn't improve. And repetition of the tests by the hospital doctors, which is, again, did not improve. So it was quite a negative study. The only thing that improved is really the accuracy and timing of the re-referral. Quite a lot of GPs said it helped them to recognize flare-up of the disease. And that's quite important because we know from lots of studies, the sooner we deal with the flare-up, the better the outcome. So that was the endpoint of the study, and no wonder no one else did it after that. There was quite a few general comments about the guidelines from the GPs. They wanted regular updates. They said it's not enough that you give us guidelines, you give us a talk, and that's it. We don't see you for 2 years. That was 1999, remember? So they wanted available on a computer disk, I assume online nowadays. And also, they wanted a hospital-based telephone advice line, which is a very interesting point because they actually did have a dedicated phone number, a mobile phone number for it, but for the 2 years of the study, not one single call was received. So that's probably what the mystery has been solved. Why did they halfway through the study decided to go and ask GPs, are you using the guidelines? Because this phone was dead. No one called. So that tells us a lot about GP's relationship with the guidelines. Correct me if I'm wrong, guys. If you like guidelines, I'm happy to write one for you. So guidelines didn't work very well, at that time at least. So how about an algorithm? And we did have, this is also from the UK GP College, connected to the Crohn's and Colitis UK, which also has a link to our Crohn's and Colitis, which talks about different movement of the patient, where you're going to classify them, and it's mostly and only to really to decide whether you refer the patient to the hospital and what's the urgency of that. So it's hardly specified. But at least what it did, as you notice down there, do you have a laser? Yeah. It at least started to incorporate some of the results to help you with it. But it's no way, well, at least in Mathemata DHB, we can send the patient and be seen within two weeks. This is hardly specific for the NHS. I've just put it here as an example. But at least it is somewhere for us to follow and to guide us where to go with some of the referrals. And this is general. This is not only for IBD, but to decide what kind of patient referral. So what's the best shared care then? I mean, so far I've told you that this is from 1999 and talking about what's the best shared care that we can follow up now. And we looked into quite a few different websites in the American, the British, and the Europeans. Probably guidelines and algorithm has been proven is of limited value. It helps to guide you, but it's not going to really influence at least the outcome of the patient. Mind you, there's no real good studies measuring this. On the other hand, GP education has been proven that's probably of the best value. And when we say about education, it's not teaching. Good, reliable communication has always come up in everywhere we talked about, and it has to be a multidisciplinary team approach with the patient in the center. The patients, because they're mostly young, and they, as I mentioned to you, they are professionals. They live with the disease for many years, so they always have to be in the center of the treatment and in the decision-making. So there's the simple thing, the Inflammatory Bowel Disease Toolkit, again by the UK GP College and linked to our website and Crohn's and Colitis website. I had a look at it. It's actually a very nice tool to go through it and to look through the different pages for it. It is time-consuming, as you expect. So I'm not sure whether it's going to be the best thing that you start flicking through it when the patient's sitting next to you, but at least it's a start. And education is, there are lots of things we can do about it and how we go about that. And it's not, we're not going to teach from, the disease distribution and the inflammation distribution and talking about TNF and interleukin-6 and all this semantics. It's more likely, mostly a reminder for where we go. And updates are very important. For example, this is a PillCam study. Where does PillCam come into Crohn's disease and IBD diagnoses and assessment? This is a work in progress. In fact, later this year in Dunedin, there'll be the gastroenterology conference, and we dedicated a whole workshop for the use of PillCam in Crohn's disease. Disease recognition. Each one of those is a talk on its own. How do you recognize a disease? The caveats, the trips, the pelvic inflammatory disease, endometriosis, and how does that overlap? Is it a Bartholin cyst or is it a rectovaginal fistula? All those things that we need to remind things. It is easy to pick up. And lots of diagnosis tips can give you the diagnosis. For example, having erythema nodosum or mouth ulcers or fistula, just simple examination. All those, by continuing your reminding about their presence, it's actually making the diagnosis much easier. The red flags, nocturnal symptoms, the test pitfalls, when do you deviate away from those test results? I mean, 5 to 10% of Crohn's disease, they never develop a high CRP. Isolated Crohn's disease in the small intestine, even the fecal calprotectin can be normal. So all those test pitfalls we have to talk about. And medication, although people think when we make a diagnosis, the medication is easy. There are lots of old wife tales when it comes to using medication. For example, every time I prescribe Asacol 4.8 grams, which is 12 tablets a day, I get a call from a pharmacist saying this is too high. I said, no, that's the recommended dose for maintenance. So there are lots of things has to be discussed. Special situation, vaccination, pregnancy, you're the gatekeepers. You're going to end up seeing those guys before us. How to handle it, how to deal with it if they want to travel, and they're having adalimumab and they have syringes. And that's where we actually got lots of the IBD nurses handling those. They've been doing a great job about recognizing flare-ups and, more importantly, when to refer. So this is just a simple thoughts of ideas about all the things that should be talked and discussed about regularly. So everyone asks GPs to do things. I thought, what's the GP's expectation of the hospital and of the specialists? What do they want from them? And now, my apologies, I'm talking on your behalf, but I thought this is the least that we should do for the GPs. I always thought a very important consultant letter detailing all the problems, and it has to be very, very clear from the disease info, the patient, the medication, clarity in its use and its side effects, what's the investigation, and also the list of vaccination and immunity, because most of those people end up on immunosuppressant. The weight has to be clearly documented, and of course the progress notes with a clear plan, and more importantly, a clear message to the GP. What do I need from you? Please vaccinate them for hepatitis B, for example. So we're trying in Waitemata DHB to get one of those letters every year in the beginning of the year for the patient and update it. And we keep adding to it to make it quite easy and clear. The other aspect of what I think GP should expect is a very good communication, is whom you're going to be calling contact with a clear line of responsibility. So again, in Waitemata DHB, I can only speak for our DHB, is we had 4 lines, major lines. First, we start with the registrar phone, and that's a nightmare to get it to because they're usually busy. So if you cannot get it to, then you go to the consultant on call. If not, then to the consultant who knows the patient, if it's already been allocated to a patient, that consultant. And if really we cannot find anyone, then we go for the CD. And unfortunately, still, despite giving all those options, it is still difficult for you to get through. And the last option, which is surprisingly how much is get used, is anyone you know. So quite a few of my GP mates, they use the last option here. They just give me a call right away, and we discuss the case. So really, what we have, I mean, we heard from Richard about the disease burden. We need to manage this disease better, and that's the bottom line. And I cannot see it be done only in the hospital service. The waiting list is getting longer. The waiting time in ED is getting longer. The best way to do it is a prevention. And since you see them before us, then there should be a good collaborative work that we can do together to control this disease. And hopefully, we can put some measurable outcomes that we can go through. So this is what hopefully open to discuss at the end of the talks, if we can just touch bases of that, and I'll be very happy to hear from you. Thank you very much.
Hi, morning. My name is Phoebe. I'm one of the inflammatory bowel disease nurse specialists in Auckland Hospital, and my colleague Jackie there, she's going to join us later in the talk. And first of all, I would like to thank Emerge Health for inviting us to this conference, and this is the disclosure statement. So earlier this year, we were approached to talk about shared care for IBD patients. Then I did some research online, and interestingly, all the definitions I can find for shared cares are from UK. And they say there should be agreement or arrangement between the IBD patients' primary healthcare providers and their secondary healthcare providers, and normally defines the roles and responsibilities of each healthcare provider in terms of early recognition of IBD flare-ups, the complications, monitoring, medication safety, and blood results, etc. And quite a few shared care agreements specifically target patients on immunomodulators like azathioprine, 6-mercaptopurine, methotrexate, and some biologics, which is quite sensible because those patients, they are more likely to have moderate to severe disease. They are more likely to under the care of a hospital specialist and also require shared care with their GP. And those medications are also more likely to cause either myelosuppression or hepatotoxicity compared to mesalazine, which has an excellent safety profile. So there are quite a few examples of the shared care agreement in the UK, and this one is for patients on methotrexate. So basically includes the information of the prescribing of methotrexate and its uncommon side effects. And then it also outlines the monitoring responsibilities. So basically, it's the hospital's responsibility to do screening bloods before commencing the treatment and also monitor the patient for their first 2 months. And once the patient is stabilized on the treatment, the monitoring responsibility fall under the primary care. The agreement also includes action and advice for GPs in response to blood monitoring and the side effects, like what action or measurement to take when you see those abnormalities, when do you call the IBD nurse to discuss, and when to stop the medication straight away. So there are other examples of the shared care, but the core information is similar. And the GP, they can choose to sign the agreement to participate in the care for the IBD patients, or if they feel like they don't have the confidence or capacity to take on, they can decline. Then the patient's care completely falls under the secondary care. So then I ponder and ask myself, do we have such shared care agreement in New Zealand? No, so because we lack such defined shared care, and here comes the problems that we face all the time. It's whose responsibility it is to monitor, and who's going to do follow-up to investigate when you see those abnormalities. And because here we don't have a clear task allocation or care coordination for IBD patients, we may either double work the patient up, or the patient may get lost in the healthcare system. And it's a consequence of lacking a framework of shared care. There have been other pilot programs in New Zealand of shared care for other diseases. I knew one for heart failure in 2011, but it didn't work out. But I tried to contact the people involved in the heart failure team, but despite my email and the phone calls, no response at all. So I also knew there was a pilot program for Hep C treatment in New Zealand before. It didn't work out, and the feedback we got was the GPs and the practitioners, they felt like Hep C is a treatable, it's a curable disease, so it's not a chronic illness. They wonder it's worth the training for some disease that's going to be short-term. And also, when they did the pilot programs, they were still using their earlier generation to treat Hep C, and because of the horrendous side effects, the GPs feel like it's too complicated to manage them. But for our IBD patients, it is a chronic illness, and the patient's going to be on their medication. Most of them will be a lifetime, and our medications got a quite manageable side effects. So I think shared care is worth trying for IBD patients. And we know that for the standards of our care for our IBD patients, there is a big gap compared to UK and the rest of Europe. But they didn't come up with a shared care agreement from nowhere. They did various of questionnaires and surveys by their IBD patients and their GPs, and with lots of issues and concerns they addressed, the shared care eventually developed. So their first round of IBD survey began in 2005, and in 2012, the third round of audit, it showed that the GPs, they often experience difficulties in obtaining the specialist advice. In respect, the lack of awareness of the roles and existence of IBD nurse specialists was also highlighted. And since then, continuous survey and improvements have been done to raise the awareness of the IBD nurses in UK. And one thing that worth mentioning is that in the 2012 survey, only 10% of the GPs involved their IBD nurse in the care of their patients. And because of all those promotions, another survey done in 2016, that figure went up to 60%. And apart from that, they started to hire more IBD nurse specialists in UK, with now the ratio is 1.5 FTE for every 250,000 population. But this year's European Crohn's and Colitis Organization, they actually recommend the ratio should be increased to 2.5 FTE, which equals 1 full-time IBD nurse for every 666 IBD patients. And also they gradually started to roll out the shared care agreements for patients on various agents. And also they worked on open access for hospital follow-ups, etc. And because there are no such survey done in New Zealand, and I wonder the issues listed in their 2012 survey are also happening here at the moment. So here comes the question: how many of you are aware of the existence of IBD nurses in your region? Good. And how many of you know how to get hold of them or actually call them for devices for your IBD patients? A few, thank you. So this is the map of all the IBD nurses in New Zealand, and done by Lydia. She's also our IBD nurse in Rotorua. There are about 19 of us, but some of them are not IBD nurse specialists. They are registered nurses with extended scope of practice in IBD. They got allocated a few hours a week to deal with IBD patients, and also most of us are not full-time. So our ratio of IBD nurse to patient care is far, far below the recommendation. And to close the gap of the standards of our care is a big project, but everything starts with a small step, and I'm not in a position to hand out your shared care agreements or to do a survey in New Zealand, but I think my small step is to introduce us to you and hopefully to raise the awareness of the IBD nurses, and also in the future to answer more phone calls from you. So for me, I think we wear three hats. We work as a care coordinator. We help them to book appointments, triage their care needs to the right specialist. And we also work as a treatment expert. We run nurse-led clinics. We manage different aspects of treatments. We commence new treatment. We do education for their disease and their treatment options. And we also do telephone consultations. And we also work as a case manager, and we follow them on their disease and treatment journey. And we act as their main point of contact. And we also provide support and advice for non-medical and psychosocial aspects. So we are multifunctional, so please use us. And I'm going to pass on to my colleague Jackie, and who's going to talk about the care we do in depth.
Hi, so I'm Jackie. I'm the full-time IBD nurse at Auckland Hospital. Phoebe is also doing IBD there. But I think we've covered the topic of shared care and kind of how badly we do it at the moment. So my talk's going to kind of focus on what we can do in the interim until we actually get a good guideline or pathway and process. So I'm going to kind of focus my limited time today on discussing some of the potential people you might see in your clinic with the and types of presentations and severities of those and what sort of treatment you can give. So hopefully some useful information. So Phoebe and I see a lot of patients with proctitis in our clinics. Common symptoms are usually rectal bleeding, urgency, some tenesmus. First-line treatment is rectal therapy, so we recommend using a mesalazine 1 gram suppository or enema. Evidence suggests that there's a no-dose response for treatment or doses over 1 gram. Steroid enemas are useful for rectal bleeding and urgency, but the preference is for mesalazine. For patients who aren't willing to embark on rectal therapy, you can use an oral mesalazine, but evidence suggests that that needs to be at a dose equal to or greater than 3.6 grams daily. And for patients with persistent disease, combination therapy actually works really well. So we know that evidence suggests that it's just as good as a course of steroids, particularly if you're using a therapeutic dose of oral mesalazine. So that's usually around 4 to 4.8 grams daily with the addition of a rectal treatment. In our clinics, we usually pop patients on this for 2 to 3 weeks. However, if they're not responding, we really encourage the GPs to contact the IBD nurse. So the registrars, as Ali's Dr. Jafar stated, are quite hard to get hold of, but we tend to float around a little bit more freely. So we really encourage you to form a relationship with your IBD nurse in your area, because they're a really good point of contact to get some information from and even facilitate a rapid access appointment for your patients to go into clinic. So for patients with persistent disease, if a GP contacts us, we can arrange appropriate investigations such as flexible sigmoidoscopy, looking at severity of disease, progression of disease, and whether their treatment needs to be escalated. So left-sided disease, combination therapy works quite well, and it really depends on where you start with in terms of the severity of disease. So patients with a mild left-sided disease, you can use oral mesalazine at about 2.4 grams with a rectal treatment. For moderate disease, you basically double the oral dose to a therapeutic 4.8 grams. Divided doses are just as good as a single dose. We tend to use split dosing if patients don't want to take 8 or 12 tablets all at once. Anything more than that, patients just don't take their medication. Steroids, we use steroids if patients don't respond to treatment within 2 or 3 weeks, or if they're deteriorating. That's oral steroid. So extensive colitis, we just rock on in there first off with combined therapy. And again, if they're having no improvement within a couple of weeks, we put them on oral steroid. First-line treatment really is an oral steroid if a patient's presenting to you and with a flare and they're on an immunosuppressant drug. We need to get them back into remission. Phoebe and I, patients tend to contact Phoebe and I when they're having a flare of their severe colitis, but they might present to you as a first presentation in clinic. So anybody presenting with 6+ bloody bowel motions a day with signs of systemic toxicity really require an acute admission for IV steroids and investigation. So again, that's where your relationship with your local IBD nurse is really handy because they can arrange or help facilitate a seamless admission into hospital. So in our case, when patients contact us, we're able to make an acute referral, contact the gastro team, liaise with the registrar consultant about the presenting complaint and the current symptoms of the patient, so that patient's basically, when they arrive, everybody's sort of expecting them. And it kind of alleviates a lot of the anxiety for the patient as well. So with regards to prednisone, the ECHO guidelines, so the European Crohn's and Colitis Organisation census group, recommends commencing patients on 40 milligrams of prednisone daily for about a week. We tend to say until symptoms settle, so that might be 1 to 2 weeks, and then reducing the weekly dose by 5 milligrams each week thereafter. So you're looking at about an 8 to 9 week course of prednisone. Shorter courses, so 3 weeks or less, are associated with an early relapse, and starting a patient on 15 milligrams of prednisone for an active flare just isn't effective. So what we recommend our patients is, if they're tapering and they might flare around the 15 to 10 milligram mark, which some of them do, we instruct them to increase their dose by 5 milligrams for an extra week or two, or certainly increase their dose back to the dose that they were asymptomatic on, and then continue to taper after a few weeks. If at that point they're flaring again, it's useful for you to pick up the phone, notify your IBD nurse so that we can contact the patient, have a chat to them, see what's going on, liaise with the consultant that they're under or a consultant, and try to get some other treatment underway or bring them into clinic. So our clinics don't tend to be as full as consultants' clinics, and they do run alongside a consultant. So we do a rapid access where they can come in and see us, and if need be, a consultant can pop in and review the patient as well. So with regards to blood monitoring, when a patient presents with a flare, it's useful to run off the usual standard bloods, including inflammatory markers and albumin. Stool cultures, we tend to perform those, particularly if we're going to be starting a patient on prednisone, and if there's profuse watery diarrhoea, we do a C. diff as well. Fecal calprotectin, we're starting to use that a little bit more, and it's quite useful in patients who sort of present with just grumbling sort of symptoms. Could be IBS or it could be IBD, so fecal calprotectin is useful, although we're not really interested in values unless they're over about 150. Mesalazine, the ECHO guidelines suggest or recommend annual monitoring of creatinine because it can cause a secondary renal impairment. And patients who you might be seeing more often are the patients coming to you for repeat prescriptions for their thiopurines, so azathioprine and mercaptopurine. They really need to have a blood test done before you give them a prescription. So azathioprine and mercaptopurine are very safe drugs to take as long as they're monitored. And I'm sure you've most of you would have met or listened to Dr. Robotham yesterday. So he's a colleague of mine, and we came up with this blood testing schedule for patients on thiopurines. And depending where they are, whether they've commenced or whether they're on maintenance dose, they have clear instructions on how often they should be getting their bloods done. We know that thiopurines cause hepatotoxicity, myelosuppression, pancreatitis, and there have been some recorded cases of death. So it's really important that they get their bloods done and that they're not getting prescriptions without those being done. You may have people coming to see you with perianal, anal pain, constant throbbing pain, fever. Left untreated, these abscesses can turn into fistulae. We try and nip things in the bud quite quickly. So initial first-line treatment is the course of antibiotics, ciprofloxacin twice daily for 3 weeks, or metronidazole 3 times daily. If that's not working, contacting the IBD nurse and really promoting us, but we're there to be used. So if we are aware of the situation, we can then refer the patient after discussing with one of our colleagues and to see the surgical chaps, so organising an MRI, incision and drainage, and for some do require set-on placement. Pregnancy. So the biggest threat to a pregnancy is a woman having an active flare, so we advocate that they don't stop their medication, or medications aren't stopped. Mesalazine and the thiopurines, azathioprine, mercaptopurine are safe during pregnancy. Prednisone, we advise caution in the first trimester because it can cause cleft palate. Methotrexate is an absolute no-no, and anybody embarking on trying to get pregnant really needs to stop the methotrexate or have that stopped 3 to 6 months prior to trying to conceive. And so if somebody's coming along to saying to you, I want to get pregnant and I'm on methotrexate, they need to be referred in to see us so that we can put a plan on place and liaise with you guys as well. Biologics are safe during pregnancy. We do defer injections or infusions in the last third trimester and then recommence those soon after childbirth. We avoid prolonged courses of antibiotics, but the take-home message really is that the medications should be continued, and if in doubt, give us a call and we can advise. We do get lots of questions about whether women should be breastfeeding, particularly on biologics. Not much is excreted into the breast milk because it is quite a large molecule. Premature babies are likely to absorb more, so we need to be a bit more cautious about that. And we just recommend with regards to vaccines that babes don't receive any live vaccines within the first year. There's some really good, the European or ECHO guidelines are really good documents. They put out some really good information on the treatment and diagnosis of UC and Crohn's, and I'm sure that you've all got lots of spare time, so you can look these up and do a bit of bedtime reading. So take-home messages, no prescriptions if they don't have bloods, and we try and always push that home with the patients, but there are the select few that just don't take that advice on board. Pregnancy, medications are okay. If in doubt, contact us. Breastfeeding's okay, vaccinations, just no live vaccines for the first year. And if the patient's known to our service, they don't need to be referred in to see the IBD nurse. It's just a matter of an email, a phone call, just contacting us, and we can go from there. Thank you.